This is Carrie Mahoney from the ARICA of Massachusetts, and thank you for joining us tonight. We're going to be waiting just about a minute or so to get started because we're expecting a few more people. So thanks for your patience, and hope you enjoy the evening. This is Carrie Mahoney from the ARICA of Massachusetts. Thanks so much for joining us tonight. We are having our webinar series, and tonight's title is Special Healthcare Needs of People with Autism Spectrum Disorder. And we're very fortunate to have Maura Sullivan to present tonight. I will be your moderator for the evening. So before we get started, let's take a moment to ensure that everyone's ready. To minimize any kind of background noise, we muted you upon participating. And if you're having any problems connecting, it's best just to log off and reconnect. So I know that you can hear us okay. Can you please chat into me so that I know we're connected? And please chat into all the panelists, the host, and the presenter. That would be terrific. So we're okay. All right, good. All right, excellent. Okay. So it's like everyone's okay with volume and the audio. So about questions, we've got a really small group tonight, so We typically will wait for questions to the end of the webinar, but we want to encourage you to raise your hand and chat in a question to us, and we will take them at any time during the presentation. So without further ado, I'd like to introduce Maura Sullivan. Maura is our Director of Governmental Affairs at the ARICA, Massachusetts, and she's also the Program Director of Operation House Call. And Maura's been at the Youth School of Medicine for the past 4 years, and presenting medical students with information on families and individuals with autism and other intellectual and developmental disabilities, and helping them to educate what is a good way of communicating, and maybe a little bit more about what to expect. The students then go into actual family homes, which is really exciting, where they get to meet with an individual and their family. So Maura's also helped expand the program for the past 4 years. Not the past 4 years, but to involve 4 medical schools. So we're very excited about that. So I'm going to pass this over to Maura, and she'll take it from here. Thank you.
Everyone, thanks to Carrie for introducing. And can everyone hear me okay? I think we're cutting in and out. We're okay. I think it's cutting in and out. Carrie. One second. Okay. No, it feels very good. Okay.
Well, we ask if they can chat in and hear us, okay?
Can anybody chat in to see if you can hear us? We just kind of feel like we lost the connection. Can hear? Okay. It feels muted for some reason, but just chat if you can't hear, or raise your hand if there's a problem. So as Carrie mentioned, I'm the program director and instructor at Operation House Call, and I'm really used to teaching medical students in person, where I can kind of gauge their and get a lot of participation. So in this environment, as Carrie mentioned, please feel free to ask questions at any time and tell me to slow down, or if you have anything that can't wait. But we will actually have time at the end for questions as well. And before we start, I just wanted to mention a couple of things. I'm a mom of 2 boys with autism and complex medical conditions. And as I teach about this subject, you will get a sense of my passion and my personal experience here, along with the facts and the figures. 2 boys with autism, me hopping every day, and they keep my hands very full, but my heart even fuller. So we'll get started. We can follow with the presentation. I'm going to break this into 3 parts. The first being, what are the healthcare needs of individuals with autism spectrum disorder? Part 2, what are some of the challenges associated with recognizing, diagnosing, and treating? And part will be, how do we work with the medical community to ensure the access to and the delivery of high-quality, compassionate care? So I'll bore you with the definition of autism spectrum disorder, because I think we all know that. And I think we also know that 1 in 68 children is the current prevalence of autism. Not if everyone knows, but individuals with autism do have increased rates of medical and psychiatric comorbidities. So is this a priority to the ARC? Because the studies that we're seeing are clear. They're highlighting poor overall health of people with intellectual disabilities like autism and serious gaps in healthcare training and availability. 52% of medical deans, 56% of medical students, and 32% of medical residency program directors believe graduates were not competent to treat people with intellectual developmental disabilities. new survey that was actually just out last week cited that many healthcare providers admittedly know little about how to care for adults with autism. 13% of doctors said that they had adequate tools or referrals resources to appropriately accommodate those with autism. So I want to stop here for a minute to just say that we're talking about medical community here, but healthcare is across all environments. Health and wellness needs to focus in all of our programming and supports people with autism and in our home life as well. I'll keep addressing that as we go as well. Okay, so what are the common medical conditions that occur with people with autism spectrum disorder, and what are those medical conditions that occur in all individuals but potentially more concernable for people with ASD? And I'll use the word comorbidities a lot because it really means a medical condition that occurs with autism for this purpose. So one of the big ones that jump out is gastrointestinal problems. Those four biggies across the top: gastroesophageal reflux disorder, constipation, diarrhea, and abdominal pain. So an increased prevalence of psychiatric disorders, sleep issues, epilepsy, and mitochondrial and metabolic disorders. Central difficulty in recognizing and characterizing medical conditions that occur in individuals with autism is really the communication difficulties that are experienced by so many affected individuals. The emerging literature right now is complicated in terms of prevalence for all of these things. In terms of GI disorders, we can see anywhere from 9% to 70% of individuals with autism reporting GI disturbances. So we'll get a little bit more into GI issues because it is definitely something that we like to pay attention to and have our doctors and providers really aware. But they may not know what mitochondrial disease is, and because it is sort of emerging over the past 5 years as a significant prevalence. But mitochondria are the tiny parts of almost every cell in your body, and they're the ones that turn calories and oxygen into energy that the cells need to work. So most people who have autism and mito are diagnosed with what's called oxidative phosphorylation disorder. So it's a disorder of the energy transport chain, which you might remember from 8th grade biology, where ADP turns to ATP. So you can imagine when this system is dysfunctional, multi-organ systems can be affected in the body, and this definitely has a significant effect, especially for people with autism. If anyone has questions about mito, you can email me, and I can send you some great links about that. But that could be a whole separate webinar, as could be psychiatric disorders as well. So let's keep going. Let's look at GI. One shows that children with autism who also had GI disturbances exhibit unexplained irritability more frequently than those who do not. Behaviors including problem behavior can be markers of abdominal pain or discomfort. And currently, practice lines for the management of ASDs do not include consideration of potential gastrointestinal problems. And in those cases that we are focusing purely on behavioral treatments will be ineffective because there's underlying pain, discomfort. Mental health, we have in transition age and adults a much higher emergency room usage, higher prevalence of psychiatric crisis and seizures seen in the emergency room. So same age cohort who are not people with autism, they have similar emergency room visits for strains, and respiratory distress. So you can see the difference between the two cohorts. Adults with autism are diagnosed markedly higher rates of mental health problems. So if you look at depression is 38% versus 17%, anxiety 39% versus 18%, bipolar 30% versus 9%, and suicide 1.6 versus 0.3. Huge one for adults with autism, for sure. Again, that could be a whole nother webinar. Maybe we will need to make it. Looking at epilepsy, 1% of children develop seizures who don't have ASD, well up to 35%. And I've seen a little bit lower percentage of that, 20 to 35 of children with ASD will develop seizures before adolescence. So significant number. And sleep issues. So disturbed sleep and nighttime awakening for 40 to 80% of children have been reported. Luckily, that seems to decrease as children get a little bit older. Thank goodness. So what are the determinants? What are the takeaways here? Problem behaviors are the single most important factor in determining the quality of life for individuals with autism and their caretakers. Individuals with autism and comorbid medical conditions may have a higher risk for problem behaviors than those who have autism and do not have medical concerns. So what we're saying is really problem behaviors can, not necessarily are, but they can be behavioral manifestations of pain and discomfort, and they need to be addressed. So this is a quick chart to look at. This is an interesting way of looking at behaviors that may indicate gastrointestinal disturbance. So this was an interesting study done where a pH probe was used in a number of children, and then data is taken through diary and through this probe. They were able to see during GI disturbance what behaviors were being exhibited. And, some of them are somewhat obvious that there could be pain or discomfort involved, others are not. The two, I would say, most significant ones that we want to pay attention to, not that not important, but self-injurious behaviors and aggression. We'll talk a little bit more about those as well. But as I mentioned, the prevalence for GI disturbance in autism is anywhere found between 9 and 70%, and that spread adds a little bit to the confusion. So I like to go by the reports from our very local experts at GH, and they note that the data suggests about half of children with autism have GI issues. So looking at half of our kids with autism having GI issues, it's a very significant consideration. We'll keep moving. The video. Okay, well, I'll set it up. Sorry about that. Okay, so behaviors that limit daily function or interfere with learning or quality of life need a full workup. They need collaboration with the educational team, with families, with caregivers, and this is really what we mean by comprehensive coordination of care. A behavioral treatment plan is developed with collaboration with medical caregivers who might be leading a medical investigation. We can run into problems where we're actually masking a significant, even dangerous medical issue. We need to stop blaming behaviors all the time on a child's autism and eliminate the idea that a child might be acting out or having behaviors from frustration or communication issues, but continually look for the underlying factors that may account for that behavior, which can be GI, but it could be a lot of other things, dental pain, headaches, earaches. If we don't find a problem it doesn't mean that we shouldn't keep looking, and if we won't find the problems if we don't consider them. So I'm going to play a short video for you. This is, I hope it's going to play, a very good example of a team collaborating with an educational team to really resolve a significant issue. This is Mun, and he has experienced a lot of different medical conditions over his time. He's actually using, they use these videos and many others to teach the Autism Treatment Network about pain and autism. So I will play this and let you watch. Hopefully it will play as I set it up. In our testing, the video played, and of course, now that we're on, it's not playing for you. But I can set it up for you. So basically, so my son was having a behavior that looked like almost a tick. He was doing instant twisting of his upper body and lower body, and he was doing it across all environments. He didn't seem super distressed while he was doing it, but it was very interruptive to his daily functioning. He couldn't really even sit and eat. He couldn't sit in tension. It was a constant twisting action. So his school team jumped on this right away and put in place a behavioral treatment plan to extinguish this behavior, which they considered to be an autistic stereotypy. And they used some reinforcement when he wasn't doing this twisting, which was tricky, and they also used some restraint. So immediately when I saw this behavior, I videotaped it and I sent it to his medical team, the hired team, and phone called to say it was there and could they look. I was afraid it was some kind of seizure or tic activity, and my son's neurologist took a look at it and said to the team, I need you to brainstorm, take a look at this behavior. I think it's medically based. And his doctor chimed in to say, I'd like to scope him, give him a colonoscopy, endoscopy, because I think it's GI. And so the way we were able to get in and get this colonoscopy done, which showed that indeed he was having severe bile reflux, and so bile was shooting up from his lower intestine, and it was getting all the way up to his esophagus, which was actually very inflamed. So when this bile was hitting his esophagus, his body was doing everything he could to avoid that connection. So twisting was posturing to stop pain. And what was so key in this was that, school was actually restraining him from doing this behavior, and it was very temporary, but the important lesson was that we really needed to collaborate between medical and education team so that we could not force him to stay in pain and really see this behavior for what it was. So look beyond the behavior. And luckily he was put on treatment right after, and very soon after, that behavior just completely disappeared. So these are really important examples of why we need to continue to look and investigate and collaborate. Babies do this. They posture when they're in pain, when they have bad colitis, colic or reflux. And so we can learn from that they can't talk and tell us all the time, and neither can a lot of our kids. And sometimes even kids and adults with autism who do language couldn't really express what's happening in their body. So they don't have to be nonverbal to be not able to communicate medical issues, pain. Okay, so we're talking about a little bit more complicated medical conditions, and we're going to continue because there's really a range of conditions that are pretty complex, can occur with autism, and have unique medical components to them. Some of these may be familiar to you. Them can occur with autism, and we know that there's a lot of medical issues in Down syndrome. Tuberous sclerosis is often also connected to autism. We've just added Smith, McGinnis, and Prader-Willi to our Department of Developmental Disabilities eligibility because they are very similar to autism. And we can also from a thing called Cornelia de Lange syndrome, which is a very severe developmental disability, and it's a genetic condition. Many years ago, Cornelia de Lange were dying, and they were dying of esophageal cancer. And no one was really picking up on the fact that these kids had severe reflux, and finally connection was made, and they were put on treatment. But they continued to get esophagus, and not until years and years later were they able to see that because of this genetic syndrome, didn't metabolize the proton pump inhibitors and antacids and things they were being treated with. They didn't metabolize them the same way, and it took a while, but they realized that these kids needed 3 times the dosing in order to prevent the deterioration caused by gastroesophageal reflux. So now we know that. So all of these things are we have to learn without these individuals being able to tell us. And so it's a lot of work, and it's complicated. But when we get to typical healthcare needs, it gets tricky as well. So even common medical conditions that occur with the same prevalence in the non-ASD population can be really challenging to identify, diagnose, treat, and then manage the treatment. Talking just about things like ear infections, strep throat, urinary tract infections, disease, abscess teeth, just aches, stomach aches, allergies. These are all really challenging for our children and adults to be able to communicate. And some of these infections and problems can get bad, and one may want to be aggressive or self-injurious when they're experiencing that kind of discomfort. So how do we work on getting to successful treatment and getting to the right diagnosis and treatment? So evaluation and assessment should be happening across all environments to the degree as possible, not just in a medical office, but everywhere. So in their day habs, in their residential facilities, in their group homes, everywhere they're at, people need to be evaluating and assessing. The patients probably could actually be a whole other webinar as well. There are many behavioral strategies to help medical professionals work with children and adults with autism. There's strategies, there's tools. We can use desensitization. We can use and social stories. We can carve out extra time in the office. Enforcement. There's all kinds of ways to get to what we need to get to in an office. An important thing is for the medical providers to be able to take the time to understand the history. If a particular medical problem in the history, that they're aware of that. Paying attention to any changes in behavior, because those are indicators. Again, can be beyond behaviors. And of course, really quick action to address any self-injurious behavior or aggression. Work educational team, doing medical rule-outs potentially before or at least in tandem with behavioral treatment plans. A real tool is to consider using data collection. So if you're a parent, if you're a provider, that you really understand the importance of collecting data or videotaping or even a diary, because this is like gold to others and medical professionals trying to figure out a puzzle. And then the diagnostic assessment piece. So a lot of people with them don't do well with the difficult diagnostic tests that are in place in order to confirm a condition. And we can weigh our options here. Can try diagnostic testing, and sometimes we fail. And if we do fail those testing options, then be flexible and offer treatment as an option. So there's ways around really making an impossible situation work for a child. So if a doctor does choose to treat because of enough symptoms without doing diagnostics, then they need to just be following up and follow through on breast and symptom improvement. And we can work slowly towards those diagnostic tests through other behavioral strategies and accommodations and modifications. Okay. So I'm going to talk a little bit about engaging the medical community. Have, as Carrie and I mentioned in the beginning, a medical student teaching program that's supported by the ARICA. We all have a first responders training, and I'm also going to take you through some of the current legislation that's supported by the ARICA that also supports medical training. Okay. So Autism House Call teaches close to 3 medical and health professionals a year all about autism and intellectual and developmental disabilities. The program focuses on 6 learning objectives, and we use 4 powerful teaching components. We have in-class instruction that's done only by parent instructor. We co-teacher experience, which is individual with intellectual or developmental disability or autism. We have a home visit, a reflection work, and an online forum. But truly, what is the most important part of this program is that we are growing interest from these doctors. And it's really easy to do once you take away the fear and you build confidence, the interest grows and the compassion is there. Do we work with them? So through learning objectives, we teach personal stories, because this is how we connect these medical students and other professionals to the learning. We talk about person-first language and thinking and modeling. We talk about building rapport and partnerships, covering difficult news, the importance of siblings and families, self-bias, and understanding the community resources that are out there, which includes the educational as well. The other important learning opportunities are there as well to grow sensitivity and awareness of disability in general, about what it's like to live with a diagnosis. This is outside of an acute care setting. To best practice skills, to learn from our families what works, what doesn't work, to see family partners in care, and to understand advocacy in the day-to-day setting. So we have some good quotes. We hear feedback all the time from our medical students and our parents and our families, how valuable this program is and how they're really learning and taking from it. So like as I mentioned, we try to teach, the teachers in Operation House Call try to teach through our personal stories. And although we're getting close time-wise, I'm going to share a couple of our stories that help us really teach these doctors and medical professionals. So we talk about person first. We want to teach the doctors who are emerging into the community how to model behavior, because they will be the ones modeling, and people will follow their lead as well. One story that I like to tell that had a very significant impact on me and my family was an emergency room visit where my son was really upset, very irritable, in pain, crying and screaming in the waiting room for some time. And there was a very upset person in the waiting room who stood up and actually said, you have to put a muzzle on that thing to me. And I was pretty upset. I didn't know really how to stop him from crying and what to do. And a doctor happened to come out and escort the man to a waiting room. And then he came back and he came right over to my son, who was still screaming, put his hands on my son's forearms underneath his elbows, and he looked right in his eyes, and he said, "Neil, I'm so sorry that you are hurting, and I'm so sorry that you have to wait. All of us here are here to help you, and that's our job, and we're going to help you, and we're going to help your mom." And he looked around the room, and he made eye contact with everyone he could, as if to say, and you're going to do the same thing that I'm doing here. And it was just the most amazing example of modeling respect for my son and really putting him first as a person and not really looking at his diagnosis. And I will tell you, the entire time we were there, this behavior was replicated by every person. And we had the most incredible, compassionate care for my son. We had times in the emergency room where that were good enough to stop, even in an emergency situation, even in a crisis, and see, how much does your son understand? How much do you want me to talk directly to him? And how much do you want me to just do what we need to do? I think reaching out and talking to families and to individuals and asking them exactly how they want things done is really what needs to happen. So we teach about addressing people directly, and if they can't communicate, then you use their family as well, but always addressing them first. So we talk a lot about delivering difficult news, and our families all tell different stories about this. But the important part here is that all diagnoses are always delivered with hope, with support, and with follow-up. We talk a lot about the importance of siblings because they are going to be with the brother or sister with autism for a very long time, for the longest time of the lifespan. Their health and well-being is critical, and they're going to be potentially decision makers and siblings' care, and their mental and physical health has to always take a priority and not be put on the back burner, even when the other children have bigger issues. And another area we try to focus a lot on is the educational system and how MDs can help here. So a lot of doctors know that they are supposed to be informed about the special education process. However, their religion, their attitudes, and their practice patterns are really not sufficient. So the vast majority of pediatricians just don't feel confident in their skills surrounding the whole special education process. So this is where we take time to walk them through it, to talk about integration, to talk about what it's like to get a private placement, a residential placement, social supports are for your kids at school, those kind of things. And it's like as children transition into adulthood and supports that they need as they exit the education system. So, keep going here. I wanted a little bit about the first responder training because we're coming close on time here. But this is a wonderful training done by the ARICA of South Norfolk, and it's available for police officers, firefighters, and emergency medicine providers. And the present instructors are first responders themselves who have direct knowledge of autism spectrum disorders through a family member. So this here is from a colleague with personal knowledge and an extraordinary investment in the program. And the goal of this training is really to complement additional training and to give them tools to assess the risk of a situation while still providing high-quality, compassionate care. And some other programs like we have Health Meet here at the ARC, Special Olympics of Massachusetts and Special Olympics in general has wonderful healthy athlete programs. The Autism Treatment Network has been a fabulous development from Autism Speaks, and the mission is really to ensure that people with autism have quality medical care. Okay. I also want to tell you just about two legislative initiatives from the ARC of Massachusetts. There are two bills on our bill platform right now, and they're really important bills. One is called the Act to Increase Current Medical Providers' Knowledge about Autism, and this bill is aimed at expanding medical providers' knowledge of autism. It tasks the Department of Public Health with designing a program to provide specialized training for autism for medical providers, and subsequently establishes a pilot program to develop what's called an autism team. The team is assembled of knowledgeable people on communication and the communication difficulties, and it can be called upon at any time to assist doctors and medical staff, inpatient, outpatient, emergency room, or diagnostic tests. Really hoping that we can pass that really great piece of legislation this year. There's another one called an Act for Supporting Individuals with Intellectual and Developmental Disabilities, and it is a bill that helps people with AD and including autism receive proper medical care and information. And it's so by requiring that all doctors, nurses, dentists, and other medical service providers complete training on how to address the unique needs of people with intellectual and developmental disabilities like autism. And we're really lucky that the Autism Commission, about 2 years ago now, held their recommendations, and they recommended that a program like Operation House Call be made mandatory across all medical schools. So we know that they really believe in that program, and we are also working at the ARC to modify the program so that it can be used for staff and people who provide services to people with autism. Okay, so I think we're finishing up right around time, and we have a couple 10 minutes for questions if anyone wants to chat them in or raise their hand. Oh, there's a question. Okay, somebody asked. Hold on. Autism a secondary diagnosis when people have the other diagnosis? Okay, that's a great question. So it can be secondary and it can be primary. So the screen that had a list of genetic conditions. Often those conditions are the primary, and autism may be a secondary diagnosis to those. We're talking about epilepsy or a GI disorder like gastroesophageal reflux. Oftentimes those are secondary diagnoses to autism, so autism would be primary. For metabolic and mitochondrial disorders, it's sort of up in the air. Instances, mito would be considered primary, and in other cases, people think that there's environmental triggers that cause mitochondrial dysfunction, and that would make mito secondary. But really would be done on an individual diagnostic basis. Well, that answers that one. Okay. Let's see. There are models of social stories and other tools available that families can access and bring to MD. That's a great question. I think that isn't social stories or other tools available through our program to teach MDs. We give them examples of what we use in our through families, but this is where I would suggest that you access whatever school systems or tabs or anywhere you can behavioral supports, because most behavioral providers will know how to create social stories. And those work great for not just medical visits, but dental visits and anything that is challenging to get through. Have any more? Yeah. So you can all the slides as well. And I also want to mention that you can always email me. I put my email big here with any questions that you didn't think of right now or you don't want to ask right now. And I will definitely get back to you. We have, I think, one more question coming. A list of MDs that are understanding of SD. So no, there really aren't lists of MDs that I could give you. There's certainly MDs who are outstanding at certain clinics, and there are clinics in the Boston area that are really fantastic. And those roles I can give at any time. I can say that the Lee Center is one of our top autism clinics. Children's Hospital also has a great clinic, and so does Boston Medical Center, and there are others, and there are many wonderful individual practitioners, but it would be a great idea if we could come up with some kind of a list. One more question. Oh, is there for medication with sleep disorders? Most definitely. I think that that's definitely a question for, each individual's doctor. But often there's medication like melatonin. Melatonin is actually really useful for sleep disorders, but there are many kids who don't respond to that as well. So I think that being to maybe a specialist for that is a good idea, but oftentimes the primary care doctor can also prescribe sleep meds as trials. Okay, a couple more. anything that families can do to help with the transition of medical care from pediatric care to adult care. Yeah, so this is a really big problem, and I think I mentioned in the beginning that most our medical field right now is not comfortable treating adults with autism. So I would say that as your child is getting towards transition age, that you begin really early trying to find a doctor who will transition if you don't have a family practice doctor already, because many families do have family practitioners who will keep going with the child, or more like a medical home, through the adult years. We're working on adults. Part of our medical training program at Simmons is focused on adult care, and we also have a small residency program going at BU that's focused on adult care as well. So hoping to turn out, again, just more interest, and that will hopefully increase tests. Okay, I have one more question here about the Laurie Center. Hold on. Are there clinics in Western Mass? The Laurie Center says they have a long wait list. I have a 22-year-old. Yeah, I would say email me if you don't mind, and I can give you some very specific names in Western Mass. Yeah, Laurie Center does have a long wait list, but what they do often do is set you up with a nurse practitioner, which I see actually is a little bit of a wave coming forward now, is nurse practitioners sort of seeing kids on the front lines, and doctors will, if issues get more intense. I would say the Laurie Center is always a good option to get in, even if it is a nurse practitioner in the beginning, just because you have a little bit more of a chance of getting into the medical treatment team. And there are doctors at the Laurie Center that see adults. So Susan Connors is fantastic for that. Okay, a couple more questions. Is there a question from medical students during your teaching sessions? Yeah. So when I mentioned before about fear, it's really a true problem. So the medical students are coming in, and they're actually really afraid of seeing people with autism because they know so little about it. So their question is often, I know how to communicate with my patient. Can't understand him or her, or if he doesn't speak, and also, how will I know, if I'm doing things right? So it's really about confidence, and what really breaks through that for them is meeting an individual in an open forum that's not a clinical setting, where they can get comfortable with maybe the use of a communication device, or really not worry so much about whether they didn't understand something, asking again or asking a family member. It really breaks through. But that's a big question is definitely around how I communicate, and it's an important piece that we work on in terms of building rapport and getting them just comfortable, really. Okay. Can you suggest anxiety clinics for adult patients with ASD? Again, Western Mass. Okay, so Western Mass is not on the tip of my tongue, but definitely email me, because I have clinics in Western Mass, and we're actually looking at expanding Operation House Call to Bay State Medical Center that way. So we're developing a lot of contacts. So, please email me, and I will get health and primary care information. Any other questions? Hold on. Just prior to mentioning the two legislative issues, you mentioned something about the Autism Commission. Was that you mentioned as a resource for parents? the autism, I think what I mentioned about the Autism Commission was that they, in their recommendations, the original group, they recommended that Operation House Call, the standing model, be mandated across all medical schools in Massachusetts because they did feel like the training was really valuable to our medical students. So now the Autism Commission is reassembling, and we're hoping that implementation of their recommendations begins. So with that supporting our program, we really feel like that gives us an extra leg up to really blanketing the rest of the state with medical training, because really it would be just a couple more medical schools to get on board. And we'll just keep churning out these youngsters who are ready and willing and curious, and that's really the goal. Let's see. Down one more time. Okay, any last questions? Okay, well, I want to thank everyone for listening to me for this long. And again, please email me with any questions, and I will definitely get back to you. And, I hope this was helpful, and I hope everyone has a good night. Thank you so much. Bye-bye.
Thank you so much, Maura. That was a terrific presentation. I'm thinking that direct care staff, that would be wonderful to be able to provide, and as well as educators. So that might be something we can do. But anyways, thank you so much for joining in tonight. I hope you enjoyed the presentation. And I also want to thank Marissa Young, our tech advisor, for helping us through the ordeal. So check back often to the ARC website. We're adding webinars all the time. And everybody have a great evening. Thank you. Bye-bye.